Um, we're going to kick off the second part of the morning session now, and we're going to stay on the theme of resuscitation and circulation. So to kick us off, we've got Chris Yap, who's an incredibly experienced and well-known speaker. He's an EM consultant in Sheffield at the Major Trauma Centre there, and he's a POCUS aficionado. Last time I chatted to him, we were setting up, I say we were setting up, he was setting up, helping with POCUS training in Ukraine, and he's a well-known international authority on POCUS. So it's a pleasure to invite him to stage to talk to us about POCUS in Resus.
Thank you, John. Matt, can I use this without the mic, or do I need to hold the mic? I need a mic. Okay, this is going to be interesting. Right, if you think, what is this idiot dressed up in his snowboard clothes? I just thought this is a conference in Zermatt. And for you, you know you're in Zermatt. For our virtual audience, 70 plus, however, it looks like a normal conference. So this idiot is dressed for the sake of the online audience, okay? So my name is Chris Yap. I'm an emergency medicine consultant in Sheffield. A lot of people always wonder, where in the world is Sheffield? Sheffield is in the north of England. I always have to say it's about 2 hours by train from London, and roughly the same latitude as Manchester. Okay, it's a beautiful city. I work in an adult-only emergency department, and we are a major trauma center for the region. So we take in, our population is about 550,000 people, but we take in patients from the region with major trauma. What's unique about Sheffield is that our neurosurgeons, our urologists, they're based in a different hospital. That's the Hallamshire Hospital, but I work in the Northern General Hospital. So who are the famous people from Sheffield? Well, we've got the Arctic Monkeys. You know, some of you who are older, like me, may remember Pulp, may remember Human League. And then some of you may recognize Sean Bean, Harry Maguire. Sheffield United is currently at the bottom of the Premier League. Okay, so this is going to be a test of whether it works or it doesn't work. So can you get your cameras up and get the QR code? I want to see whether you're a friend or foe with me. Okay, so hold on, just bear with me. It should be working. Can you see the "Are you a skier, snowboarder" on? Everybody okay on the QR code? So you do need to respond in a while. So these are the bits where you can keep quiet, but later I'll need you to do some shouting out for choices. Okay? Everybody got a choice? Yeah? Okay, okay. A few more seconds for the QR code, and then can we triple finger? Let's see whether this works. Let's see whether this works. Yes! Okay, good. So I'm not alone. And there's 6% of you who don't like snow. So if you're in the audience and you don't like snow, maybe you should find somewhere else to go to. Okay, so my next question will be, can we switch to? Okay. There you go. So what do you do in your work, for your work? Okay, so I'm going to try again. This is a word cloud, so I think we can activate it, yeah. I just want to, let's keep it up. It should be able to switch it anyway. Yeah, it's all right. 9 of you. It just gives me an idea, okay, of what you do. That is brilliant. So we have quite an eclectic mix of people here, okay? So my next question is, we'll move on to it anyway. It's okay, you can keep up on the slide. Yeah, it's okay. So do you use POCUS in your role? That's my question for you. Very good. Okay, so I'm going to start feeling like an imposter now, because a lot of you are POCUS users, and I'm just going to cover how I try to use POCUS in our resus room. Okay, I'm not sexy like you, and I don't do pre-hospital medicine. I don't wear orange jumpsuits. I don't fly in helicopters. I used to, but that was a long, long time ago. Anyway, so hopefully there'll still be something useful for you to learn. Okay. Okay, we're back to the slides. And okay, so that was the question. So I want to cover some basics first. And for some of you, this may be already really very easy. Okay, this is a subcostal view, and it's a very common view that we use in echo and life support for the trauma patient because the approach is easy. And this is a normal heart on the right side. Okay, the clever ones among you may find something wrong, but this is a normal beating heart, and we want to know this is a beating heart. Okay, and we use a liver, and if you want to look for free fluid, then I'll show you in a while what free fluid looks like. So can anyone tell me, this is the bit where you need to do a bit of shouting. What is wrong with this picture? Excellent. Very good. So first principle for ultrasound is free fluid is black, right? So very important principle, okay? So on the left, I just want to show you that all these scans are not just done by me. It's not, the show is not just shows, it's not just about me. The scan on the left is done by a trainee. So I do a bit of supervision with my trainees, 1-to-1, 3 hours every 3 months for them. So what some basic principles are, remember I said black is fluid. So this is someone with a pericardial effusion. It's one of our patients. The one at the bottom is a pleural effusion. And the important thing to distinguish is this thing called the descending aorta, okay? If fluid sits anterior to the descending aorta, that's a pericardial effusion. If fluid goes behind, then that's a pleural effusion. There's also other things that we look at, very simple. I'm a really very simple person because that's why I do EM. Like we call it the rule of thirds, okay? So basically you look at this, 1, 2, 3. And roughly, they're about the same. They should be about the same size, okay? I'm not Felix, so I'm not a cardiologist, so he'll be able to tell you specifically for age and sex, there's a bit of variation, okay? But my eyes are getting older, so all I can see is roughly they're about the same, and that's good enough for me, okay? Okay, so lung ultrasound. So we use this you can use this in trauma, you can use this in your medical patient, okay? So this one is just a basic slide showing to you what we talk about lung sliding. A lot of you may have heard about this. And this is a normal lung with normal lung sliding, okay? This is a right upper quadrant view and a left upper quadrant view, and I'm trying to show you a normal scan as well, where we got the liver, diaphragm, mirror image artifact, and remember what color or what should fluid look like? Fantastic, so there's nothing black there, okay? Diaphragm, spleen, no black, no black. So hopefully that's normal, okay? Right, so are there any pitfalls with POCUS? The answer is yes, and that's why the uptake of POCUS is an issue. There are lots of barriers. This is a study done by Hamid Shakuhi, Andrew Litapolo in Massachusetts, in Boston. So they're a great set of guys. They run an amazing, amazing fellowship program for ultrasound. So they did a study, a retrospective survey of M&M cases over a period of 12 months. And this chart is really interesting. So sometimes you might get drawn towards the right, where it talks about cases where POCUS had not been performed, but if it had been used, it might have prevented M&M. And that's what they conclude in their summary, okay? That 33% of patients may have benefited from POCUS, right? But actually, I think what's important is to look at this side, where POCUS was performed, and when it was used, it may have contributed to M&M. So it's about 7 cases, and very good of them. They broke down those 7 cases, okay? And yes, there's lots of things to read, but I'm just going to summarize. And basically, the summary is what this guy has said, okay? And the summary is, if you don't use it well, you don't interpret it well, you don't apply it well, you're going to get it wrong, okay? So it highlights the importance when you do POCUS about training. So it's not just about doing a course. And we always talk about, we talk about finding a co-pilot once you start learning POCUS. Always find, who wants to be a millionaire? Always have someone to ring, someone to ask the audience for help. So it's very important with POCUS because oftentimes we can't always get it right, okay? Okay, this is the next bit of my bit where it's going to be interactive, where I need you to shout out. So there are 9 cases here. John's going to tell me when I run out of time, all right? So we may not be able to get through these 9 cases. I tried to bring in a bit of winter and a bit of snow stuff, okay, relevant to, but I can tell you, like, for example, bottom left, that's we're just going slightly off-piece from the resus room, okay? So it's a bit cryptic. Tension is, yes, it's about tension pneumothorax, so but I thought put a DIN setting, even though I'm not a skier. The cautions about trees don't move, it's just about something that didn't move, okay? And the bottom right is me trying to climb up, but I'm in crouched all four positions. And the case is actually about a woman that was crouched, okay? But I just thought I'll just show myself crouched on fours first. So I'll leave it to the audience now. You can choose a case, tell me, and then we'll get through it. Anyone shout out something? Hateful eight. Okay. Anybody heard about the hateful eight before? Yeah, it's sign of badness basically. A patient who looks a bit pale, a bit clammy, getting a bit confused. Blood pressure can be unrecordable, will be a bit low. Heart rate's unreliable. Okay. So we had a trauma call, and it was my South African colleague who was leading the trauma. And because he led the trauma, I was free to do the primary survey with the ultrasound machine. So the story was single stab wound to the chest, and he was able to converse, but he was clammy, and his blood pressure wasn't the best for a young man. So the first thing I did was because of the site of where it was, I did a lung ultrasound, which I haven't got it here, but effectively it was normal. There was sliding in his lung. So I thought, oh, that's a surprise. So let's go and do a subcostal view, and this is his subcostal view. And you can see, because I did it, the image is crap, okay? But what can you see? What's important is, you can see here, whoops, sorry guys. Yeah, you can see that there's free fluid there, okay? Happy with that? That there's a pericardial effusion, a very large pericardial effusion, okay? And in fact, it's showing signs of tamponade. I've shown a normal heart on the right side of the screen, and on the left is that same patient, okay? So this is his personal long axis view, and anteriorly over the front, if I can get this to work, a dot there. Nope. Anyway, this patient went to cardiothoracic theaters in just under 9 minutes. Okay, the nurse got so excited how quickly we got. She took this picture and she put it on Twitter. So we had to tell her to take it down. We had to tell her to take it down immediately because it wasn't appropriate for that time. Okay, right, right. Oops. No. I need your help in clicking on the home page for me. On the home. Thank you. The house, bottom left. Yeah. And again, maybe. Okay, so another choice. I'm probably going to run out of time now, but COVID. Very good. So query. Oh, I need your help. Sorry. Okay. Thank you. So query COVID. So this patient was the early days of COVID. You know, you can remember how inundated we were with the latest POCUS findings, the latest way to ventilate a patient, et cetera, et cetera. So this was a 33-year-old man of African origin, Black African origin, and he was breathless for 3 days. Okay, so he came to the dirty area of our Resus where we think the patients were had COVID. He was unable to lie on his back, so he was sat forward, really like, you know, almost like a tripod position. So he was the first time I did an echo with someone in a tripod position. His blood pressure, interestingly, was 240, above 240. And this was his lung ultrasound, so right and on his left. For those of you who know what ultrasound looks like, you can see that there's lots of what we call B lines, and then there's free fluid here, and there's free fluid there. Okay, so it's black. So this chap had quite a lot of pleural effusions, and he had pulmonary edema. Okay. This is his heart. So this, hopefully, let's see whether we can get this to work. Let's try the question. What abnormalities do you see? There's more than one answer, okay? And the reason why I like to use Slido is if you get it wrong, it doesn't matter for you. Yeah. I'm not going to stop you from going up to the ski slope. So if we can switch the answer, thank you. It should appear. If you 3 fingers up, and then choose Safari. Yeah, it's okay. Fantastic. So everybody's right. So he's got impaired LV function. It's mild, but he's got impaired LV function. He does have an enlarged left atrium. He's got LVH, and he has a pericardial effusion. So well done, everybody. Okay. So back to the slides again, please. Thank you. So this is his short axis view, okay? And so normal, as I say, I'm quite a simple EM person. So the way I teach people is to just put a dot or put your finger in the middle, and you can see that it's not. It should come and squeeze right to the middle, and it really isn't doing that. Okay. So yeah. So this guy had quite significant impairment, and he had renal failure. Nicole, I just need your help back to the home screen. Oh yeah. Okay, I think we've got time for one more case, and then, as I said, because of all my faffing. PA and Ross. Okay, so PA and Ross. PA and Ross, please. Okay, so this one, I won't be questioning you. I'm just going to show you some cases where sometimes you can get anchored in a certain thing, all right? So it's a 78-year-old gentleman, prostate CA, awaiting radiotherapy, collapsed at home. So comes in PA, but had Ross, and he's got an eye gel. This is ECG, and my clever colleague starts writing, and it really makes a diagnosis based on the ECG, which is fantastic. So I tell my trainee, okay, let's do an echo. Tell me about the LV function, okay? So this is a personal long axis view, and this is true to life. Our views are not rarely perfect, and that's what you need to remember. You don't have to expect a great echo, okay? So I'm going to cycle through some of the scans. This is a short axis view, okay? And then finally, this is a four-chamber view. Subcostal view. So remember, I asked my trainee to look at the LV function. We thought, oh, LV function, okay, heart's pumping, it's not bad. So I ranked, so we were just thinking, what is the diagnosis for this patient? Then so we thought, well, we need to scan the head, and we think, okay, possibly it could be PE, but we're not quite sure. Okay, so we rang the cardiologist anyway because we're going to send the patient to the scan. Then he said, oh yeah, that's really good. It's obviously a PE. I said, what do you mean? He said, well, Chris, this patient, can you not see has got a clot? So if you look down here, there's a bit of a clot there. Okay. If you look up here, there's a bit of a clot there. So it's interesting how easily we can get anchored or forget to look at the overall picture. Okay. So I'm sorry I'm running out of time. I'm happy to show you some of my other cases, but POCUS can be used in trauma, can be used in a medical patient, okay? But really, I'm not winning, am I? Can you go to my hourglass to tell me time is up? Time is up. Okay, so before I go on to like really questions, I just want to talk about one case, okay? If I can get this to advance. So this is the next case I'm going to talk about is about a patient. Is whether POCUS would have made a difference in one of my cases, in one of my colleagues' cases. So they told me about this patient who. So our red phone went off. It was query posterior stroke, and they had an AB replacement a few days earlier. And then he basically on standing felt dizzy, and there was significant postural hypotension. So they rang the cardiologist to come and perform an echo because they were suspecting this patient had surgery. Okay, but all they saw was a small pericardial effusion. And then so they thought something's not quite right. So basically this patient was in Resus for quite a while, and they thought they just need to get a CT. And surprise, surprise, the CT showed a massive right hemothorax. So this was a patient who was shocked, and if we had applied, some simple POCUS shock ultrasound, we probably could have identified the hemothorax a lot earlier. So sometimes, even in my center, it's a challenge for me to try and educate people to use ultrasound. It takes lots of practice, practice, but it also takes somebody to guide you and correct you when you get it wrong. But in the end, it will save you time. Okay. But what are the barriers? What are the barriers to learning? So there is a paper produced by a North American group of internal physicians, and they talked about basically in summary what the barriers is: a lack of a device, lack of training, lack of supervision, lack of time, and lack of quality assurance. So if you're a POCUS lead or you have an interest in ultrasound and you want to educate, these are the barriers that you probably have to just break down, identify, and try to get over. So what do I do for myself? In our department, we managed to bid for 3 machines. In terms of training, I run an online monthly POCUS club, which you're all welcome to attend. And I'll put up a QR code to my Twitter page and my Instagram handle, and I'll explain that a little bit more. Supervision I provide, as I said, I get protected time from my boss has allowed me to have protected time to supervise my trainees one-to-one, 3 hours every 3 months, okay? And it works for them. So that, in terms of lack of time, if you don't have time to go in, so I call it reverse engineering. If you know someone's got a pneumothorax on the chest x-ray, then put a probe on to see what absent lung sliding looks like. If you know someone's got ascites, put a probe on, then you know what free fluid looks like, okay? Quality assurance, and that's the hardest thing, having the time to review the scans. So that's my weak point at the moment. I've got colleagues in London, around the country, who are excellent. They run image review sessions. They have protected time to review the scans. In fact, a colleague in London called Ashley Matthews, he now reviews about 70% of his patients, of his scans that are done in his department. So with that, I thank you. Thank you for inviting me. Twitter is where I put most of the ultrasound stuff. Instagram is mostly my snowboarding, but when I run POCUS clubs, I will advertise both on Instagram and as well as Twitter. And my YouTube channel is just a new channel, and I have some bits about blogs and some talks from our POCUS club. All right, so thank you very much for inviting me. I'm not sure whether you're going to get me back again next year, but please continue your POCUS journey. I'm happy to answer any questions. All right, thank you.
Thank you very much. Thank you. It was incredibly illuminating. I have to say, when I do POCUS, it's more like when you're behind a snowboard and you just see that big poof of snow. Nothing is really clear for me. But I think looking at your slides, I think I'd need more practice and I need more supervision. Any questions? Well, so you have managed to get some protected time in your department to teach and do this. My experience with POCUS is that it is incredibly labor intensive to teach and maintain a program. So how do you do it? Because clearly you put hours and hours into this.
Coming to places like this helps me keep motivated, basically. So you need to have a plan here, have a strategy, and start simple. So I started with simple POCUS clubs, training my local registrars, and then I started off doing it supervision during clinical time. And then when I realized it had for myself, it had an impact on my patients that I was looking after. So I'll be supervising a trainee when they came in their protected time, but I was on the shop floor. And then I realized I went back to a patient a few hours after or something, because I was supervising. That's when I realized. So I presented a spreadsheet to my clinical director saying, we've got 18 trainees, 3 hours every 6 months initially. And then when I first ran it for the first 6 months, I realized we needed to follow up. So I've now increased it in the last 6 months to 3 hours every 3 months for every training that comes through.
It's amazing, isn't it? Because when you look at something like POCUS, we managed to close the loop with this effort, but we probably don't look at a lot of our other practice in the same light.
Yep.
And I'm not entirely sure what makes it different, because I think POCUS feels new and to me a little bit unfamiliar and scary. But I think it's very difficult to close that loop.
Yeah. I think we can learn a lot from the anaesthetists, where in terms of learning, when you learn a skill, you have a trainee who's doing it, and there's a consultant literally standing over them and watching them, and sometimes we don't do enough of that in EM, in emergency medicine, because of time pressures, and that's why with the protected time, the trainees appreciate it.
Brilliant. Okay. Thank you very, very much. It was amazing.